Hi friends, welcome back to the channel. Often we mention in our operative notes that the case was uneventful. Today's case is a case of a mature cataract in which the events that unfolded are quite contrary to that statement. So here I am after staining the anterior capsule with Trypan blue. I am filling the anterior chamber with 1.4% sodium hyaluronate, which is a cohesive viscoelastic. And after completing the second side port incision, we go ahead and make a biplanar 2.8mm clear corneal incision. Mature cataracts are often associated with some sort of intumescence. So here we are incising the anterior capsule with a 26 gauge bent cystotome, and since there was no egression of any liquefied cortex, I go ahead with the Capsulorhexis. So I've decided to do a two-stage Capsulorhexis, wherein my first rhexis is going to be a very small one through which I'm going to try and aspirate some of the liquefied cortex. But to my surprise, there was no liquefied cortex and the corticocapsular adhesions were pretty firm. As you can see from this cannula, it was a dry aspirate. So now I've decided to enlarge this Capsulorhexis. So the Utrata forceps is quite a handy instrument in this maneuver, and I have a slightly undersized Capsulorhexis of about 4.5 to 4.75 millimeters diameter. Generally, mature cataracts have a very easy rotation, but as you saw in this case, the corticocapsular adhesions are very firm. So I'm burping out some viscoelastic and I decide to do a visco dissection with 2% HPMC. It has to be done in a controlled manner and in a multi-quadrant fashion, always checking the intraocular pressure digitally because I do not want a posterior capsular blowout. So I am burping out viscoelastic after every step and then doing the visco dissection in different quadrants. So I've been successful in breaking the corticocapsular adhesions and I get a free nucleus rotation. And I then move on to the nucleofractus part of the phacoemulsification. So here I am doing a direct chop to try and divide this nucleus, and immediately I notice a loss of glow. I see a very dark fundus glow. I do not see a normal red reflex. So I'm asking my assistant to check this patient's ultrasound report, and he comes back and tells me that the ultrasound was normal. So there is only one explanation of this phenomena. While staining the anterior capsule, the Trypan blue dye has migrated from the anterior chamber through the zonules into the vitreous cavity and stained the vitreous. As a result of this, I have lost the red reflex. Difference, this can be a hindrance to the surgeon because whilst emulsifying the nuclear fragments, the red reflex provides you a background which gives you a contrast. You can have a certain depth perception. You can gauge the distance the posterior capsule is from your phaco tip. If you have a dark fundus glow like this, you lose contrast and you cannot gauge the depth of the operative field. So this may cause complications such as posterior capsular tear. And if a PC rent occurs, you may not detect it in time because the PC rent is usually detected against the red reflex of the fundus. So because of the loss of the contrast, a PC rent might go unnoticed. You might cause the unwanted enlargement of a PC rent and you may end up with nucleus drop, which you do not want. So now the option for me is to slow down the speed of my phacoemulsification process, take it slow. I've reduced the bottle height slightly and I'm doing a slow motion phacoemulsification. I'm using 300 millimeters of mercury of vacuum with 30 cc per minute aspiration flow rate, and I'm on a 40% phaco power right now. So the cutting efficiency of the phaco tip goes down, but it slows down the surgical process. Eventually, as you will see now, that the glow is getting better, because as the fluid is circulating in the eye, it is pulling out the dye also, and it is going into the aspiration of the phaco tip. So the glow improves gradually and with time, but at the same time it is important to take precautions. So I'm using my Y blunt instrument or the nucleus dialer as a secondary chopper. I do not want to keep a sharp instrument here wherein I don't have a good view of the posterior capsule, so I'm using the Y for a lateral separation. During the last piece emulsification, the Y dialer, the blunt instrument, is behind my phaco tip and always protecting the PC from trampolining upwards. So after the nucleus has been completely emulsified, we are left with a nice purple fundal glow as a result of the Trypan blue staining the vitreous. A careful bimanual irrigation aspiration is done to remove all the remnant cortical fibers, and we are being very careful to not use too much of vacuum. So we're attempting a hydro-IOL implantation, but you can see that the iris has come into my main incision, so I'm pushing it back with a 27 gauge hydration cannula. And again I attempt a hydro-IOL implantation, but the iris has now decided to plug the main incision. So to prevent iris prolapse, I'm using a cohesive viscoelastic in the subincisional zones near the side port and just underneath the main incision. Dear friends, cohesive viscoelastics are very good in maintaining space, and they will be helpful in pushing the iris back. I am not inserting this viscoelastic in the capsular bag because I'm still going to do a hydro-IOL implantation. So I've just used the cohesive viscoelastic to push the iris back, and quickly I'm doing a hydro-IOL implantation. So after IOL implantation, you can see that the next event that occurred is that the subincisional iris has started to bleed. Probably because of the repeated prolapses from the main incision, it's become shaft and it's become fragile. So the blood vessels there have started to bleed. So the solution for that is that we do a very good side port hydration and pressurize the anterior chamber so that it stops this bleeding. So 1 week post-operatively, the patient has 636 uncorrected vision, and the IOL is well centered, the fundus glow has returned to normal, all the dye has been absorbed, and the vitreous staining has been reversed. So this concludes the case. Thanks for watching. If you have any questions, I'll take them in the comment section below.